reply. We can keep insulting him.
We've got green square.
Morning, Julie.
So that will catch up.
So 20-second delay.
Morning.
Anita, have you got any free time tomorrow?
Let me just have a look at my diary. Right. I know, I keep meaning to catch up with you, actually. Hold on 1 second.
Shall I unmute?
Leave it on private, and then when you listen to what when David's about to start, then it's go public.
Yes,
Brilliant.
I can make some time. When were
and
you
can
thinking,
you hear the sound?
Sharon?
I'm quite flexible tomorrow, so I can work around you.
Okay.
Hold on. Then there's the apart from 1 till 3, but other than that, I'm quite flexible.
Okay. All right. What about at? Might go on a bit actually.
Great.
Tell you what about
Right.
12:30?
Yeah, that's fine. That's fine.
Okay, I'll send you an invite actually before I think of it. Should we do it in Teams?
Yeah, that's fine. Thank you.
Thank you very much. Let me know if you pick up any.
Oh God, sorry, I've done it on the wrong day. Sorry, just gonna done it today rather than tomorrow.
We're not live on YouTube yet, are we, Anita? Just in case.
We are streaming apparently, so I shouldn't have said that. I apologise.
Richard normally gives us a countdown, doesn't he? So I think we're okay.
Apparently he was explaining to us earlier that although we're not live, if somebody were to log on and then kind of rewind, they could hear what we're saying at the moment, which is why we were told to be a little bit careful. But anyway.
I hope you've all been watching Line of Duty. Very, very important. The question I'll pose to you, you can answer it at the end, is: am I Ted Hastings or Patricia Carmichael? This is the question.
I'm actually ashamed to say I've never watched it.
No! Oh, Sharon.
Sharon,
come on.
Sharon, I'm with you on that. I've never seen it, and my friends can't believe it.
Yeah, and mine. I've not watched it.
I haven't either.
It's very good.
Kind of people to work with. Well, anyway, if anyone does rewind it, they'll enjoy that little conversation.
I think you are Patricia Carmichael, but do we call you the governor?
That's terrible. I see myself as Ted with the wee donkey. But I understand now that I'm basically a careerist sort of. Right. Oh, 59. Sorry, we're not there yet. Sorry. At 10 o'clock. Welcome everybody. My name is David Nicholson. I'm the chair of the Worcestershire Acute Hospitals NHS Trust, and welcome to our board meeting this morning. I've got some apologies for absence. I've got Richard Oostrom and Waqar Azmi. It is of course Eid now, so Eid Mubarak to all of our colleagues in the NHS and listening at home. welcome to Joe Ringsell from the Health Watch. Welcome. And welcome to, I think Harvey's also on the call. Harvey is, I don't know whether the right word is shadowing me. I think it used to be called shadowing me, but it's a long shadow these days because you don't actually meet each other. She's my reverse mentor as part of the arrangements we put in place to improve our understanding of inclusion and diversity in the trust. So welcome to you.
Thank you.
We'll also be joined later on in a conversation about sepsis, I understand, from a number of our clinical colleagues who Julie's organised to come along. So I don't know when they'll join us, but no doubt they will at some stage. So welcome to them when they do. As everyone is aware, at the start of our meeting, it's really important that we think about the services that we provide directly to our patients, and we have a patient story. And can I welcome David Ashmore to the meeting? I think, according to this, I can call you Dave. Is that right, David?
That's good, thank you.
Yeah. Well, welcome. You're going to tell your story. We'll be talking about some quite important strategic issues and big issues later on. But it's really important that at the beginning of the meeting we get grounded in the reality of our patients' experience of the services that we are responsible for, to ensure that we can take note of those and do whatever is necessary, both to improve the outcomes and the experience of our patient. So thanks very much for coming, Dave. Thanks for sharing your story with us. Am I passing over to Paula, who's going to introduce the item? Paula.
Yes. Thank you, Chair. Welcome, David. We haven't had a chance to catch up. I have read your story with real interest. So without further ado, I just want to pass over to you to tell your story.
Thank you. I appreciate having this opportunity. It's been a fairly quick year from my point of view, but probably one of the most important in my life. And I've seen and observed things throughout. And I wanted to give feedback to the right people. So first of all, can I thank Anna for listening for an hour and a half to what I had to say about the last year and converting it to the document that I hope you've all seen. There've actually been a couple of more neighbours that are connected to the NHS that have helped with this as well. There's a lady called Christy that used to work in your Rowan suite. She now works at QE, but she's been invaluable. And as a lady called Helen King, who I believe recently worked in your quality improvement department. So they're both neighbours that have guided me as well. And then finally, Alissa Robinson, who I went to school with and grew up with, and is now Director of Nursing, I believe, for surgical. And I said, look, I want to give this feedback. It's really important to me. What's the best way of giving it? So an email would have been nice, or a letter in, I know that. But when I was told about this format, I was really appreciative, so thank you. You've seen the story, you know what's happened over the last year, so no need to go into detail. But just a couple of people I'd like to sort of highlight and mention really. Goes without saying, Steve Pandy and his team have been amazing. And it's not just the care, it's the leadership he's demonstrated, the communication skills, his style, his standards. I've got very high standards set in me when I joined the Royal Navy as an 18, and now just ending my police career, but really as an assessor and an adult trainer within a specialised skill. I can't help but look at how other people perform and relate that to like what are the key areas of good performance and what are the potential learning points. So that's what I like to think I can perhaps bring as a dynamic to this feedback, rather than just saying thank you very much. So yeah, Steve Pandy's team stood out. Dr. Churn and his team in the Rowan suite, in particular when my own organisation, West Mercia Police, I've got to be honest, the leadership there at the moment is not the best it's been, and that will change soon. But it affected how I was dealt with when I came to medically retire, because I should have physically retired at the end of April, and my treatment plan was always going to go beyond April, so I couldn't go back to work. But I had a hell of a challenge with convincing my force medical advisor that I was critically ill. It turned out he hadn't seen my medical records. He must have just Googled bowel cancer and made a decision. So Dr. Churn's team were actually really, really crucial to me getting my case to what we call the selected medical practitioner, who sits above the force doctor, who looked at it with disgust and said, I can't believe we've come to this stage where we're trying to fight with you to keep you at work when you can't work. So Dr. Chern's team, his secretary, was amazing for that. The district nurses, they've been coming in to see me now since January, and it's never always the same one, but I cannot fault any of them. They've all been perfect. And it's not just the treatment, it's the communication skills. You know, I've gone through this living alone, and isolated or shielded for a lot of it. So that interaction with the NHS staff's been really important to me. And even going in for the radiological and chemotherapy last summer, it was quite sad when it came to an end, because A, the treatment wasn't hurting me, and it was just really nice to go in and see people every day and build up those relationships with them. And you know, they're all credit to you, really. Then Aikenbury 4, so to get me into the operation was an absolute, that week was quite challenging, because the operation got cancelled on the 5th of January. It was due to happen the next morning. I've picked up on Radio 4 in the morning that Worcestershire had to stop doing elective operations, so I was expecting it, really. But I cannot underestimate the work that Steve Pandy and his team took that week to get me in on the 13th of January. And then for Aikenbury 4 to have me in there that week, and the level of care I got was exceptional. I didn't know what to expect, so obviously I've never been in that position before. But I can honestly say that the team, because it's been the most challenging year you've probably had as a trust, I imagine. And that was probably the highlight. And that week I turned up for my operation probably would have been your hardest week. So there were people coming into Aikenbury 4 to form a team, and you couldn't tell. You know, I thought they all worked there normally, but it was only as the week went on I would realise that people had been drafted in from other areas of work. So that really stood out to me. And there was a healthcare assistant there in particular. I don't know her full name, but her name's Anna Marie, and she was remarkable. She was coming in on her own at night to sort of do the work needed doing, but she was so professional. It was a pleasure to watch her operate. That's all I'll say. And very, very, the communication skills are brilliant. So they're the key highlights for me. So that support during my medical application to retire, the overall treatment throughout, it couldn't have gone better in my opinion. That fight to get me in the operating theatre that week of the 13th was remarkable, because I was on the point of having to go private, and it was looking at about £25,000. But I didn't mind spending the money, I'd have spent it, but I'd built up a relationship with Steve Pandy and his team by then, and I've actually felt quite guilty having someone else do it. And I know they all know each other at that level, you know, they've probably all worked together, but to me, I wanted Steve Pandy to have responsibility for doing that crucial stage, that operation. And it was a good choice, because I ended up in, after histology, I was category A, and it doesn't get better than that, so I'm really grateful for that. My own learning points were certainly after the chemo radiation phase. I had a long wait then, and because I was living alone, getting a bit bored, whatever, any excuse, but I'd started to eat a bit more and put weight on, so that was a learning point for me. You know, you can do yourself a big favour by being as fit as possible for the procedure, and it's going to help with your recovery. And I just, a bit of feedback perhaps to the NHS is, if you've got a patient that you know would benefit from that, drive it home to them. Don't be soft about it. Just get into them and say, look, it's really important. And certainly this year, I think someone in my position, being on your own and trying to get yourself ready for that, it was easier some evenings just to eat a bit more for comfort, and you think, well, I'll do it better next week, or be more resilient, and before you know it, you put a few kilograms on that you shouldn't have done. I did lose, because Mr. Pandy was quite direct with me in December. I'm really grateful he put me on the liver reduction diet, and within 3 months I'd lost 30 kilograms. So that was a real good boost for me. Another bit of feedback just for the board, and you might have answers to this, but when I went on the 25th of November for the operation first, but couldn't have it because I went into atrial fibrillation, I was sent back up to the ward when I called the walk of shame. But there were 2 other patients in my ward with me that day, and I had to wait there most of the day while they sorted out a couple of things before I could go home. And as both patients came back up from their procedures, they were both white males in their 80s, and I was really saddened to hear. One woke up first and had a conversation with me that I was embarrassed to hear. It was racially motivated, basically, and it really surprised me. And I'm sat there thinking, I've just retired as a police officer at midnight this morning, and if I wasn't in this environment, I'd be probably having a positive conversation with him about what he shouldn't be saying. And he didn't really stop when staff were coming into the ward, and that's what alarmed me a bit. And then he went, and the second one woke up, and virtually it was like the same conversation carried on. I thought, well, if these staff are putting up with this day in, day out off that demographic, or I don't know what proportion of the patients, so I thought more about that and applied my normal process. This isn't work. But right, what is there to tell me coming in? If I behave in that way, it won't be tolerated, and it will be directly dealt with. There's nothing to indicate that. So is it something you just tolerate and put up with? Because those staff tolerated it, and they just let it go straight over their heads, which was admirable. But should they be doing that is my question. So what's wrapped around them for them to report it, that a patient's being problematic in that regard? And if they put the head above the parapet, what protection do they get? I mean, my assessment of both these men opposite me were that they were probably scared, I think, at heart about the treatment they were going to have or what could be wrong with them. And I get that, and fear can then motivate inappropriate behaviour, and that's exactly what was playing out. But they weren't challenged, stopped, and it was a strange day for me anyway. But that's the thing I went home with, feeling quite saddened about. Really, was the staff there that are there to help them and saving their lives, and it wasn't nice to hear. So just as an interest point of view, what is there for your staff in that environment?
Okay, thanks for that, Dave. I mean, there are a whole series of issues. I think can we take the issue of racism towards the end and get into and just talk about the service to begin with? So, can I ask for any questions and comments that people want to make about the story first of all? Paula.
So, Dave, thank you for that story and for the lovely praise for our staff. That's amazing. Is there anything else we could have? I appreciate from the racially charged comments, we can address that with our HR director towards the end. But was there anything else that we could have done differently that would have made your journey better?
I've had a long time to think about it and review the whole year, and I can't. It hasn't gone seamlessly. And I've ended up from the procedure with a couple of complications, but they were briefed to me well in advance. And I just think of what would it have been like for Mr. Pandy to do that operation that day to make sure I ended up being in category after. And the consequences I've been left with are absolutely immaterial to me. So, and I think a lot of my family and friends find that hard to understand why I'm so understanding. But when you've been in my shoes, I was just grateful from the outset that I could be treated, because it was touch and go whether I could be. And like I said, I could have spent £25,000 going privately, but I don't think it would have been better. I think it would have not been as good, because that leadership and the sort of softer skills shown throughout have really made this different for me and really helped.
Thank you.
Yes. Anita.
Yeah, I mean, Dave, thank you for that. And I have to echo Paula's comments. I mean, some of the things you said about the care you received from our staff was really fantastic. And I think the thing that I really loved hearing was the fact that, there were people that were being redeployed onto that ward that didn't normally work in that ward. And yet it wasn't even apparent to you initially that was the case. I mean, that is real testimony to how well we manage that situation. So I think I have first of all a note for Paula, really, to say that we need to make sure that these kind words for the nurses, for that HCA that Dave particularly mentioned, we need to make sure that they hear this. So I think that's the first thing. I think my question for you, Dave, is that given, as you said, that when it happened and it was, all the stuff about elective surgery was being cancelled and you got in, and we all knew COVID was going on, it must have been quite a scary time for you. And you've talked about, maybe things like, giving some fairly directive advice about weight control might have been helpful, or and we'll talk about sort of behaviours whilst a patient. We'll talk about that separately. But was there anything that we could have done that would have helped you feel more comfortable? Because I mean, obviously, given your job, you probably are a relatively resilient and strong person. But I can imagine that for some patients, that must have been would have been a really terrifying experience, given the background of everything that was going on at the time. So, was there something that you think we could have done that might have helped?
No, and I'll just start off with a simple answer, no, and just go into why it's no, because I don't scare easily. I've had a really great 30-year career in the police and been involved in some very interesting things at a national level, and I don't think I'd have got through that 30 years if I wasn't, a certain type of character. But I've never at any stage, even from the point where the doctor first told me there was a tumour, we had to go to different surgery. I had to go home alone to an empty house and whatever. It never felt, no point have I got overly upset about this. That's just how I am. I'm more concerned about would it affect my son or people close to me. So that's just how I am, really. And then to go into the treatment phase, and then through the scans, then meeting Mr. Pandy for the first time, seeing the tumour, on the screen. It just helped me get it all in perspective, and I knew from the outset that I've got a team that were there to look after me. And one of the things he said to me a couple of times was, leave the worrying to me, you just do what you can do to make this an easier process. And that's what will always stick with me, and that's where I thought he's a good leader as well as an excellent surgeon. And it wasn't just him, it was everyone I came into contact with, really. So I think a learning point for yourselves is whatever you're doing is good. And keep that up, keep reviewing it by all means, but I think bearing in mind the year you've had as a trust and what I saw of it was fantastic. So, yeah.
Any other questions? Can I just say something, Dave? I mean, one of the things for me, colorectal surgery colorectal cancer is a good example in a sense of, to get the best outcomes for the patients, a whole series of things need to happen. You need a population that understands what the kind of risky behaviours are. You need people who can look at the signs and symptoms and see them. You need GPs that can spot it and get the diagnosis done quickly. You need the surgeons to do great surgery. You need great aftercare. I just wondered, particularly at the front end, about how quickly you were diagnosed and whether that might have been picked up earlier or whatever.
That was an issue. I didn't know whether it was one that applied to this board here, because I'm not sure of the dynamic between a surgery and the board. But when I first went in, I noticed I was losing blood, so I went in fairly quickly. So that's never happened before, and it can't be right. And I didn't know much about the subject at all, to be fair. So I went in fairly early on and was seen by a GP who did a physical examination as well, and was told not to worry, and they thought that I perhaps had an internal fissure. And I left the surgery thinking, well, that's a big relief then, there's nothing to worry about. But I wasn't entirely sure that was right, because I knew how much I've been losing blood, and it didn't stop. And this is where I have to put my hands up. So I'd gone in at the beginning of 2019, and at about the same time I'd found out indirectly, my mother's Canadian and I haven't had contact with her since I was a child, really, but I found out that she got bowel cancer and it spread to her liver, and was she died in August 2019 in the end. So I was aware that was going on, but without any direct contact. And I carried on bleeding all that time. But 2019, my force was divorcing itself from Warwickshire Police, and because I ran all the armed assets and all the operational sort of risk area of the business, I was so busy in 2019. It was one of those things I thought I perhaps should go back to the doctor. I forgot where time was, and it wasn't in fact until I got back from Canada in March. I think it was April 2020 I went back to the GP. So I thought I'd left it about 6 months and expecting to get told off for leaving it that long, and actually when we calculated it was more like nearly a year and a half. So that was my fault for leaving it that long. But the key thing here is I then got in touch with the practice manager, because obviously I've gone into your stream then, and the tumour's found, it's confirmed as malignant, and I'm thinking, right, there's learning points here for the GP surgery, and I have to say they've dealt with it far better than I ever anticipated. Their practice manager took on board what I said straight away, and by the time I'd spoken to her, they'd already taken remedial action. So the GP I'd seen initially was in fact in a probationary period. That GP had already voluntarily extended their own probationary period. They'd done a report into what had happened that day in my examination, and then their head of sort of learning development in the surgery had already held a workshop for them to make sure they understood what had happened with me and to approve the referrals, the referral policy. So that's all I wanted to hear from them, really. You know, I wasn't after an apology or it's our fault. That's not how I operate. And I had a part to play as well by not going in quick enough after the first visit. So I'm really reassured by that surgery and how they responded to it. And I just hope that they are putting that to practice. I mean, I've got no way of judging or gauging that, but I've got no reason not to believe they're not taking that seriously.
Thanks, Dave. Although you're absolutely right, we don't run general practice.
Yeah.
But we are interested in getting the best outcomes for our patients.
Yeah.
And late diagnosis, whether it's an issue in general practice or an issue with us, is a really important part of that. And we need to talk to general practice about that and how we can do it. Mike?
Yeah, because they might be a bit anxious about making too many referrals, I gather. People want to make referrals all the time when you'll just bounce them back saying, why did you refer that one? But then obviously, with mine, knowing what we know now, and that's really important to me. It's not what I knew that day I first went in.
Yeah.
Knowing what I know now, it would have been a referral, I like to think. So yeah.
Okay, Mike, do you want to say anything about all that?
Yeah, I mean, I think it's always a difficult judgment about when to refer, and I think you're right. It's being aware of what the fallback position should be. One-off bleed's fine, but you know, I think the learning for general practice is around that. And I'm so glad that you've had a good experience with Mr. Panding. I've known him for a long time through training him, among other things.
Yeah.
So technically he is an excellent surgeon, and I'm glad you've had a good outcome.
Yeah, no, it's unbelievable, really. Thank you.
Okay, well, thanks for that, Dave. Thanks for giving us the feedback that you've given us. The next part of what you'd said was about the racism that you'd seen, and I understand your argument about these men may have been in very vulnerable positions and all the rest of it, but in a sense the lack of challenge or the lack of clarity from us as an organisation about what sort of behaviour is acceptable or not has to be an issue for us. Anybody want to take that up in the group? Yes, Anita.
Yes, Sir David, thank you. I have to say I was deeply troubled by that part of the story, Dave. I think I really would appreciate some assurance from the team about what should have happened in that situation. I assume we should have spoken. Our staff should have spoken to those staff, to those patients. You didn't want to listen to it, and had there been patients in your room who were perhaps from ethnic minorities, I mean that's really not acceptable at all. So I'd really like to understand from Tina or someone, what should have happened there, and how can we make sure that it does happen going forward.
Yeah, I'll bring Tina in a minute, but can I ask Simon wants to say something before we move on.
Thanks, David. Yes, and thanks, Dave, for your story. I'm a recent addition to the board as a non-exec director, and one of my duties I've taken on is as the lead for the board with our Black and Minority Ethnic Network of staff, which in itself is recently formed. So what I will do is I'm in regular contact with the chair of that network. I'll have a conversation with her about the experience you had, just to gauge from the network how widespread this is. I mean, I'm sure Tina is our lead on people who have things to say from that point of view, but I'll certainly raise it with her, and I've noted it down here because I think that's something that we as a board and as an organisation would want to find ways to appropriately challenge and deal with.
Thanks, Simon. Matthew.
Yeah, thanks. Thanks, Dave. My name's Matthew Hopkins. I'm the Chief Executive of the Trust. Thank you for sharing that information. I know Tina's probably going to set out some of the practical things that we're doing, but I think this also falls into the wider issues that our staff experience of physical and verbal abuse, which we have, as stated very clearly at a previous board, the view that we take and the mandate that the board's given me to really make sure that we bear down heavily on any member of the public that verbally or physically abuses our staff, and to make sure that those individuals are reported to the police and appropriate actions are taken in line with that. And we have had some success in that in the past, in making sure that we're able to bring people to account for their behaviours. But as you say, there is really quite a pernicious issue of racism that I think probably you're right. I think our staff have developed a tolerance to it, and I think that's the worrying part. We really have to make sure that our tolerance and that calibration of our tolerance is absolutely at the right level, so that we do not accept that kind of behaviour in any part of our organisation, or indeed any part of the county. And I welcome Simon's reference to supporting the chair of our main network in really focusing on the things that are going to make a difference to our staff. And as you say, being very clear about our expectations.
Okay. Tina.
Yeah, just Matthew's covered some of the points, but just to add, so what should have happened is that the members of staff should have had the confidence to tackle that inappropriate behaviour there and then, or if they needed support to go to any of their work colleagues at that time and to escalate it. And as Matthew said, we've got a policy with various levels of escalation, calling security, etc., if necessary. So that's what should have happened. Clearly, we're on a culture journey within the organisation, and we've spent a lot of time educating colleagues around, discrimination and how we should be behaving towards each other and being active allies with each other. So if we feel people being treated inappropriately, that we act, for them. And part of this is how we educate our patients and service users and public to this. And I think that's, David, thank you for raising this, because I think that's where we've got further work to do. And we'll, as Simon said, we'll take this back to our networks. We've got networks for ethnic minority colleagues, disability and LGBT plus colleagues as well. So we'll take it back to all three forums to get their input on how we take this forward.
That's really good to hear. I mean, from my point of view, I imagine there would be a mechanism in place, and I think the challenge is for your staff to, at what point do they reach their tipping point with thinking, right, I actually need to engage the support of my colleagues and management here, or this is just, I can just ignore this and get on with my job, because they've got that better understanding of why perhaps that person's been like that at that time. But I just sat there thinking, I wonder how much they put up with day in, day out. Just from the snapshot of time I was in there for, it was embarrassing, really. And I know, society will change. As another generation come through, better education and understanding of these issues, it probably won't be as bad. But it's just, as a strategic lead of the organisation, just reviewing and keep on top of that for the benefit of your staff. And a simple bit of advice to the people coming in through the front door when they get there might make a bit of difference with some people. So.
Yeah, make really great points there. Thank you,
Anita.
Thanks, for David. I'm pleased to hear that there was a process that should have happened, but can I just say, just to kind of pick up on something that Matthew said, and I know he said it with the best intention, so this isn't a criticism of him. The reality is nobody tolerates this. nobody gets used to this.
Yeah.
When things like this happen, you maybe have to just kind of try and get on with it, get on with your job, but actually it wears you down.
Yeah,
and we have got staff who what worries me is that they didn't feel that either they felt confident enough to deal with it, or that they didn't feel confident enough that we as an organisation would take it seriously. And I actually see this as really serious. This is key to us being inclusive. And you know, as I say, whatever anybody says when they say, oh yeah, I'm used to it, trust me, you're never used to it. You never become used to it. You know, it wears you down. It makes you feel unvalued. It makes you feel disrespected. It makes you feel that maybe you don't care about your job in the end, and therefore patient outcomes will suffer in the end if we don't deal with this. So please, really glad you mentioned this, Dave. I don't think it's the kind of thing we would be aware of. Certainly, I've not heard that before, and I'm genuinely appalled by it. So thank you,
Sharon.
Thank you. I think I was, and thank you for sharing with us. It was really useful, and actually hearing the compassion that you had for the staff, and actually the enormousness of the job that they've been doing over the last 12 months. I mean, I was literally going to make the same points as Anita. It does get wearing if you face it on a regular basis, and it affects your actual well-being in the workplace as well. So as the wellbeing guardian, I just want to give you that confidence that actually we are taking these things seriously. And it was only yesterday that I was in a meeting discussing strategically how can we start looking at, you know, staff's wellbeing and the enormousness of the job, particularly as we come out of COVID-19 and the pandemic.
Yeah, I mean, from my point of view, Sharon, I've had 30 years in a job where people didn't like me because of what I wore and what I stood for, and I just convert that because, you know, what must it be like having that every day, day in, day out, just because of your appearance, or English wasn't your first language, and, you know, all these other issues that then it's there forever, isn't it? And they tolerate it while they're dealing with that patient, but like you said, Anita, it doesn't go away, does it? You hear what's being said and how you're being dealt with. So
I think you're preaching to the converted on this point.
Oh yeah, I'm sure I am, Sharon. It's for me, it was just important to raise this as a learning point, and well, it's just more for, I didn't see the trust or the NHS doing anything wrong. I just thought, can they have some reassurance that that's in place for them if they're dealing with these people day in, day out.
Okay, thanks for that feedback, and thanks for the comments people make. I just wanted to say a few things to kind of sort of, just on the racism bit. You know, make it absolutely clear from this board, this is completely unacceptable from a board perspective. And we'll do everything we can to support our staff through all of that, including giving them the kind of support that they need. And Tina's talked about that, but I think that's an absolute no. And it isn't the responsibility of our ethnic minority staff to, in a sense, lead this. You know, this is a responsibility of all of us to make it happen. So I absolutely take that, and we'll do whatever we need to do, and we can reflect on that as a board later about what we might do to make that happen. But thanks. I mean, it's particularly nice, I think, to be told by a policeman that this is, you know.
Retired.
Oh, sorry, yeah. You'll always be a policeman. You won't be able to avoid that. Okay, so that's on the racism thing. And, you know, zero tolerance, absolutely no question about all of that from us. There are a couple of sort of clinical things that I've taken from this that I think just need to be followed up by us. One of them is the weight control bit about are we giving the right sort of advice? Are we providing patients with the right kind of support and help to make it?
I was definitely getting the right advice.
Yeah,
it was for me personally it was a learning point for me more than anything, that in the moments of boredom and on the build up to the operation, I perhaps could have been a bit stricter with myself. I guess the only point of contact really with people physically before the op would have been the pre-op check. So they took my weight and everything at that point, and I can remember going in and thinking, I wonder if they'll say anything about my weight, because I put quite a bit on by then, and it wasn't mentioned. But then obviously I had the atrial fibrillation incident. I was actually in the anaesthetic room getting the epidural put in, so I was that close to having the operation. And luckily, Mr. Pandy took the decision not to operate that day. while we got to the bottom of the AF. So.
Yeah, so I understand. There's enough in that for us to have to think about that. The second clinical issue, I think, was around referral guidelines, to make sure that if there are referral guidelines, are they up to date? Are they right? Are they understood by Japan? To make sure that we get that we get that right. And then the final bit is we need to make sure that many of the people who you've identified in this, we do feed back to them the story that you get and how the board recognises the contribution that they made. I mean, you mentioned one or two names. The one I think I'd highlight that we really do need to seek out is Anna Marie.
Yeah.
It seems to me, often healthcare assistants, they have most contact with patients. They do a fantastic job and often are unsung heroes in all of that. So particularly if we can hunt Anna Marie out and thank them.
I identified about 20 staff that probably had direct contact with me that week, and they were all brilliant. But I don't know whether it's because I was on the epidural and it was the middle of the night, so it was just Anna Marie coming in. But it's the way she was, she was apologetic for waking me up and how she dealt with it. It was deadly efficient. It was nice to watch from a layman's point of view. You think it's worth waking up to watch this bit because she was really good. So I don't like singling out individuals, but I would like her personally told. I appreciate that.
I agree, and we should, highlight her role. Paula, do you want to say anything about that before we wind up?
Yeah, just thank you, Dave, for highlighting the staff's names, and I totally agree with the chair around the healthcare assistants. I've only had another healthcare assistant brought to my attention this week called Rachel, who's gone above and beyond. So we're now looking at a special recognition award from the chief nurse, so that they can have something to absolutely hold on to. So I want you to know that I will absolutely feed back your story to the ward, and I'm sure Michael will support me in making sure Mr. Pandy gets that information, and we will take that forward. But thank you so much for praising them. They really do need that at the moment.
Yeah, they fully deserve it, and like I say, set against the year you've all had, I've been amazed, really. I'm grateful. So.
Well, thanks very much, David, and we will hopefully keep in contact. I hope your health, obviously with your pension, but I hope your health it continues to improve, and you know that we're always there should you require us. So thanks very much, David.
And thanks for your time. Thanks for letting me, because this is so much better than just sending in an email. I really appreciate it.
Yeah. Okay. Thanks very much.
Bye bye.
Okay. Thanks, David. So let's move on. Are there any items of any other business that I need to be identified? No? Good. The declarations of interest, they are on the website. Minutes of a previous meeting. A couple of typos have been identified to me. Page 8, medial is medical, and page 8, endure should be ensure. Any other? Matthew?
Yeah, thanks, Chair. On page 5, I wonder if we can just be explicit that where I was celebrating the return of many staff from shielding, I think would be important to put in there, just to get the context right. Thanks.
Thank you. Okay. Yes, Anita.
And just one where I wondered if we could just reword it on page 7. It actually refers to a comment I made, which is 7th paragraph down. It starts, Ms. Day queried the criteria. I wonder if we could just reword that. What I was basically trying to ask the question was about, it said that business cases would only be approved if they improve financials, and I was saying, can I just get your confirmation that if something impacted quality of care, that would be a valid reason as well? And I got that confirmation. So it's just to kind of tighten up the wording around that, please. Thank you.
With those changes, are they a reasonable record? They are, yes, thank you. Action log. Rebecca?
Yes, thank you, Chair. Let me just switch screens. As you can see, we've only got one action on the log, which is due at a later meeting. All of our actions are closed, and there's nothing for this meeting to address. Thank you.
Very good. Thank you for that.
David, apologies. I've just realised there was just one other minor thing to correct in the minutes on page 13, where in the Audit and Assurance Committee report, where it says Mr. Horwath would join the committee. He's already a member of the committee. It was that he was going to become committee vice chair. Was what that was about. Sorry, apologies.
No, it's fine. You know how flexible I am about people interrupting me as I'm moving through the agenda. Okay, thank you. Right, Chair's report. All I want to say is that to confirm that Julie Moore is currently acting as chair of QGC, whilst the Chief Medical Officer recruitment is going ahead. Let's then move on to the Chief Executive's report. Matthew.
Thank you, Chair, and just really got a couple of updates since this paper was written to share with the board.
Can I say, Matthew, can everyone hear you? Your sound seems a bit off to me. Is
it? Right, I do apologise. Let me just see if I can. If I turn my camera off, see if that helps in terms of the Wi-Fi. Is that better?
I'm afraid, Matthew.
No
better. I'll come off my headphones. Apologies, colleagues. Is that better?
That's better for me.
Okay. All right. Thanks. Apologies for that. So the couple of updates just in relation to the ICS development and the development of the ICS model. I just want to draw attention for non-executive directors to the two non-exec summits that are planned, one later this month on the 25th of May and one on the 29th of June, which I'm hoping the invitations have gone out to, and I hope that there'll be good attendance. That will help to shape, I think, both the ICS operating model but also the place level model as well. So I thought it'd be helpful to reference that. Also, just to reference in relation to the annual planning point there in relation to our submissions. Paul and I met with the CCG earlier this week to review our activity plan, and a further iteration of that is under development with essentially changes to our COVID infection control arrangements, which should lead to a higher activity level over the first half of the year. So happy to report back on that in due course once that work has been completed. But the aim is to put ourselves in a better position to apply for the elective recovery fund in relation to our activity levels compared to the 1920 baseline. Also, just to note for the board that whilst there isn't a planning paper for our internal planning process this month, significant work is underway to develop that roadmap to reduce our operating deficit through the various transformation schemes that we have on the runway, as it were, and also making sure that we are really mapping all of the schemes that we've got planned over the next 3 years to make sure that we have ourselves properly organised, where we're not stretching ourselves too thin in relation to capacity and capability, but that we're also doing things in the right sequence in order to address both the quality, performance and long-term financial plan for the organisation. And clearly our ambition is to get to a good CQC rating on the next full inspection, but also make sure that we are reducing significantly our operating expenditure and our annual operating deficit. One point to note, Chair, that your reference to me in relation to the work the South Warwickshire group were doing, I've made connection with the leadership there, and we're looking to share experience, share learning, particularly in relation to how they've worked with community services to shift the place of care to the lowest cost setting, and how they've done that through various mechanisms with their community services and so on. So more to follow on some of those points at the board workshop in June in relation to our medium-term financial plan. In relation to the Chief Medical Officer recruitment process, we've had a really good response and we're in the process of shortlisting at the moment. So again, more on that as that progresses for the board over the next couple of weeks, with interviews due at the beginning of June. And then finally, just to note, referencing my reports to previous board meetings about our concerns in relation to the unmet need amongst our community that has developed over the COVID period. We are now seeing, I think, some of that unmet need being realised through both significant increases in emergency activity, particularly in relation to walk-in patients who our clinical teams are describing are much sicker than the normal picture that they would experience in terms of people that are making their own way to our emergency departments. But we've also seen an increase in cancer referrals quite significantly, and obviously the media coverage, I guess, reflects that nationally that's a picture that is being seen elsewhere. And the reference to the accelerator bid in the coverage today, we indeed from Hereford and Worcestershire did submit an accelerator bid. Unfortunately, it was not accepted, but the elements of the bid we're progressing with nonetheless as part of our restoration plan. I'm sure that Paul, if requested, can touch on some of that later in the meeting. So I'm confident that we'll be covering some of the points in relation to emergency activity and performance, cancer performance during the integrated performance report. But I think it's important to note that I guess the national trend of unmet need now coming into our hospitals is a picture that we're seeing locally in Worcestershire. So, Chair, I'll pause there. Happy to take any questions.
Thanks. Okay, any questions? Anita.
Thank you, Chair. Matthew, I noticed, I think it was yesterday, I got an email to say that the virtual quality and safety walkabouts programme was now being paused, and because there was some thinking going on about how we were going to do this going forward. I wondered whether that was a signal that we were talking about going back to physical walkabouts, given how important quality and safety walkabouts were, and therefore does this actually signal, do you and Sir David have a view at the moment about when you are thinking we go back to face-to-face meetings?
Well, no, I don't think we've yet discussed that, certainly at the executive team level. I mean, we are having some face-to-face meetings within the rooms that are able to accommodate that, but certainly we've not yet got into the discussion about any reduction in the management of our infection control arrangements, other than the reference that I made earlier to how our operating theatres can become more productive. I don't know whether, Paulo, you want to reference that as the executive infection control.
I think you're absolutely right, Matthew. And Anita, can I pick this up with you later, because I'm not sure who you got that email from, but I will pick that up and we'll take that forward. They shouldn't be stopping in any shape or form.
I'm glad you've said that, Paula, because I was going to, I haven't seen this email, but anyway, we can take that. A good point that you make, Anita. We can take that forward. Okay, there are some issues I think that you've talked about, Matthew, that we will pick up undoubtedly in the integrated performance report conversation. So can we then move on to the integrated performance report? Can I say, in this, some of our colleagues, our clinical colleagues, are going to join us, and I know that they are all kind of doing proper work while we're doing this, and I'm just conscious that when we get them, we need to use them to best effect, and I don't know what the timing for them actually coming on the call is. Can somebody tell me that?
Yes, Chair. We've offered an invite between the 11 and half 11 slot. Obviously, there's a number of different people who will be dropping into the session, so I will alert you as to their attendance. If we can continue with the item and then pause as they join us.
Well, yeah, you tell me when to pause and I'll pause, because whatever we're talking about, we need to get the sepsis stuff done when they arrive. Okay. That's great. That's great. Okay, integrated performance report. Vicky.
Thank you, Chair. Good morning, everyone. So this is the month 12 integrated performance report for 2020-2021. It's been approved at TME and has also been assured through the subcommittees of the board. We've identified a number of key messages in the executive summary, which we'd like to draw to the board's attention, some of which we've already talked about. So the first one is the impact of COVID on our activity and our waiting times 1 year on, and in there we've got a comprehensive table across all points of delivery showing what our activity levels have been over the past 12 months compared to the previous period. We've also picking up our NHS planning guidance and the regime that we've got in place, which Matthew has just referred to as well, in terms of this paper was written at a point in time. Quality and safety, so the infection prevention and control position for our year end as of March, and our compliance with those annual targets. Sepsis, which we'll get the presentation on when the team join us, and people and culture in terms of staff absence reduction, given that shielding, we also expected that to be reduced as well in April when the shielding flag comes off. And then the financial position as of month 12, which I'm sure Robert will talk in some detail about. Thank you, Chair. Okay,
so how do we want to, what are the issues that you particularly want to talk about? I you know, from my perspective, there are two that I want to talk about, but they may not be the only one. One is emergency care, and a real worry that we're sliding back into a place where we've come, and secondly, finance, that we're actually not having a proper grip on the current expenditure. So they're the two things I want to talk about. Are there other things that people want to raise as part of that? Anita.
The third area that I would add to those that'd be good to have a conversation about would be about the fact that although we are picking up activity levels, we're not yet even at 100% for a lot of things, which means that as we currently are, the waiting lists are actually still getting bigger, and therefore some idea about what we think the trajectory is at the moment, and given that waiting lists are going to be such a priority for us.
Okay, and Simon?
Thanks, David. I think mine's sort of related to that as well. As we go through the report, when we get to assurance levels, for a number of the areas, a number of the boxes there, we've got sort of comments that when expected to move to next level of assurance, and it's not sort of date led, understandably so, given that the situation that we're in, it's more generic in terms of, I'm just looking at one I hear on page 33, when we are consistently meeting the operational standards of cancer waiting times, which is fair enough. But I'm just wondering, at what stage do we think we are now going to be able to put dates on some of these when we envisage assurance levels changing? And I do say again, I appreciate the climate everybody's working in, but at some stage, I think we do start to need setting targets for ourselves, because otherwise those comments lose their value.
Yeah, really good point. We'll cover that. Who else has got their hand up? I can't see anybody else.
I think Chair Collins has his hand up.
Oh, Colin, sorry, Colin. Yeah.
Thank you, Chair. It really links to your point about finance. There's a comment under the heading People and Culture, which says, I've noticed the continued increase in hours worked. So I'm hoping that we can explore the impact that is having on our financial position.
Okay, thank you. Let's take those. So let's start off with urgent and emergency care ED performance. What's our trajectory for improvement, and what's our analysis? Are we going backwards, or are we going forwards? I don't know who wants to talk to this, Matthew or Paul, perhaps.
Shall I pick that up, Chair? Matthew?
Yes, Paul. Sorry, yes, go on.
Yeah. So yes, the position is tight at the moment, but we're not actually going backwards, in the sense that if you look at the position for January and February, the 4-hour performance was around 75% for both January and February, and the March position is just over 80%. So things improved in March, and actually, although we're talking about 2021, the position in April increased to 81%. So the 4-hour performance is actually, over the last couple of months, gone up by 6%. I'd also draw the board's attention to the point that Matthew made, which is where we're seeing quite an increase in attendance. So if you look around January and February, the total attendances in our departments was 10,400 and 9,800. In March, that jumped to just under 13,500, and in April, it's increased to over 15,000. So we're seeing significant increases in presentation, and at the same time, we have seen the performance, as I said, increase by 6%. Having said that, there have been occasions when performance, particularly at the Worcester site, has been as low as low 50% over the weekend, and we've had a significant increase in the number of patients that no longer need to be in our hospital, remaining there due to difficulties on discharge. And I think we need to be clear, it's a combination of, at times we haven't got everything in order with transport books, electronic discharge notice done, TTOs ready, but by and large it has been around the capacity issue for supporting patients in the community, and also issues around infection control management in the community hospitals and being able to access those beds, as there have been regular occasions when beds have been unused and we've had patients who needed to be discharged. So I think where we are, Matthew required from the Home First Board earlier this week a change in our approach around managing throughput and demand 4 times a day, starting at 8:30 in the morning and finishing at 8:30 at night. That was introduced yesterday, and I know one should never take a one-off, but I would just point out that yesterday the peak of discharges with the introduction of that moved forward by 2 hours, from 6 p.m. to 4 p.m. So we need to keep a track on that. We are also looking to reverse a number of decisions that have been put in place over the last couple of months. I don't want to go into detail about why the decisions were made, but in the COVID period we had 3 underlying principles. One was that any patient with a Rockwood score of 7 or below would go home. The second principle was around discharge to assess, so there would not be any assessment in the hospital unless the patient was highly complex, and they should go home to be assessed. And the third principle was that if a patient was ready for discharge and was in the discharge lounge by midday with their electronic discharge and their TTOs, they would be discharged that day. Now those 3 things were key to us seeing that significant improvement in flow in the April to June period in 2020, and they've all disappeared. So the aim is to put those 3 back in place. And you'll also be aware that during the COVID period we ran a 7-day bronze, silver, gold command system, and having had a discussion with Matthew and Mike and Paula in particular, we're aiming to close down the command structure for COVID, hopefully in a week's time, and we're going to replace that with a full 7-day command structure on patient flow. And we now have support from colleagues in the CCG and the Healthcare Trust, so it will be a system-wide command structure to manage flow on a very detailed basis. Now that is not sustainable to do it every day, but we're looking to do it for 7 days a week for 2 to 3 months to manage and ensure that the actions needed to improve flow out of the hospital, and also to look at managing patients within the community rather than presenting at the front door, is reinforced. And then we would be looking just to monitor after that 8 to 12 week period of putting the command structure in place. And I think the other point that's worth recognising is that we have identified some quite significant capacity issues social care provided, and our colleagues County Council with Paula Furnable and the CCG with Mary Gay are supporting from next month a significant increase in the hours available for social care from the beginning of June. So I think those are the actions that we're taking. And as I say, I would acknowledge that there have been times, I mean, I know we're talking about 2021, but certainly in April and May, there have been times when the 4-hour performance has been extremely poor. But as I said, I would add that both for March and then going into April and May, as at today, performance is actually 6% above the previous period. I would also point out, although I'm sure the board would expect this rather than having it pointed out, but you will be aware that the pre-COVID year we were running with around about 50 12-hour DTAs a month, and there were none in April, and there's been none to date in May.
Thanks, Paul. A very, as I say, a comprehensive response to the point that I made. And my guess is that, you know, if you do all of the things that you've said you'll do, will improve even more. So thanks for that. And I as I say, we're all concerned, aren't we, that we slip back rather than go forward, because this is important for us all. I'm very conscious, I've just been told now that our colleagues have joined us. So, Matthew, I don't know whether you want to say anything quickly before...
trick that we as a system have missed is that the growth in demand at our front door essentially leads to a growth in the social care package and a growth in demand into community beds. I mean, it's an obvious point, but I think the wider system response to increased capacity on the basis of increased unmet demand, I think, has been a cause of part of the problem. Of course, as Paul said, the social care package capacity is being increased. It's, in my view, too late, and I think that's what's created some of the challenges that we're experiencing. Our length of stay has gone up, so as Paul said, there's things that we need to do to address bringing our length of stay down from over 6 days back to between 4 and 5 days, which is usually our optimal average length of stay. And this problem of medically fit for discharge patients, those patients that don't have a reason to reside in the acute hospital, is our key system challenge and the priority. Now, yes, the capacity issues will address that, but the mindset and the culture of working at pace, I think, is the key thing that we need to work at through our place ICS developments with our partners. So those are the additional comments I wanted to make, Chair.
Thanks, Matthew. Can I then, we move on to sepsis, and Julie, are you going to introduce this part of the conversation?
I will do, thank you, yes. And I can see 3 of the clinical colleagues here. As you know, the Quality Committee has been looking at sepsis in some depth for some time, and at the last meeting we had an excellent presentation from our clinical colleagues about the work that's going on, not all of which will be showing through into the headline figures at the moment. So I think it will be really helpful if the same, and I'd like to thank them for coming from their clinical time to actually give this, because we found it immensely helpful at the last committee to hear directly what was going on in the divisions, and there was a huge amount of work, and the committee was very impressed by what's going on. So I don't know who's going to go first. Rebecca, I think we've got the actual presentation we had at Quality Committee.
Yes, that's within page 95 of your pack. I will see if I can share it on the screen. I don't know if that would be possible, but yeah, page 95 of your pack refers. Thanks.
And it's quite difficult to orchestrate who's going to speak first, so I'm just going to let you guys go on your own. And Mike, you're first in my order, so I think you are probably first anyway.
So I'm going to let Mike McLinden lead on this because he's done all the work.
Thank you, Mike. So, yes, thank you very much for inviting me to come and just update with what's been happening regarding the sepsis quality improvement work. If Rebecca is able to show some slides, that'd be great. If not, I can try and share my screen if that's a reasonable alternative. I've got a presentation available.
If you can try, I'm struggling because I'm also doing notes at the same time and my computer keeps stopping. So bear with me, and I will try, but it may be easier if you do it. So let's have a try.
In which case, I'll try and share the screen, and I've just got a couple of slides just to illustrate the points, really, if that's okay. Is everybody able to see that screen?
Yeah, that's great.
Wonderful. So the first thing to mention is obviously the sepsis project's been running for the last 5 or 6 years or so that I've been leading on this. Initially, we had a starting point where we had very little data on our sepsis performance. So obviously any initial work provided quite quick gains in terms of our sepsis performance figures, which specifically around the time when it started, we were looking around the sequence regarding screening of sepsis, suspected sepsis, and antibiotic delivery within an hour. All of which we kind of made decent headway on in the first couple of years of the project. And as you can see now, moving up towards the kind of top right-hand corner of the graph, certainly within ED, where we spent a large focus of our attention around 2018, 2019, we've had good sustained performance in terms of ED screening and treatment, and more recently improvements in Sepsis 6 completion as well, which is obviously very pleasing. And I think in that area, it's very much become business as usual, which is obviously what we were aiming for. With regards to the inpatient group, screening for sepsis has been up and down, it's fair to say, but is generally on a trend to improvement. Antibiotic delivery within an hour, I think, is quite well recognised as potentially the key step in managing septic patients, and I think that translates to all areas of the medical and nursing staff. So that performance has been pretty well maintained. What I would say is that the dip that you would see in both of those around September, October is, I think, the hangover we're seeing from the initial wave of COVID, where clearly some of the audit data we had wasn't quite as extensive as we had previously, and also clearly clinical practice and the clinical group we were dealing with were very different. So that goes some way to explain that sharp dip around September, October at the end of last year. I suppose the main talking point, the reason why I'm here, is just to explain or try and highlight what we're doing to try and improve sepsis 6 completion within the inpatient group, because I think it's fair to say this is definitely the hardest nut to crack from a management perspective, because although the quality bundle of 6 steps is relatively straightforward, it does require engagement in terms of activating when to do it, and also to make sure that it is done effectively in a timely fashion. I just want to flip very quickly to show the other side of the story, which is when we look at our HSMR related to sepsis. When we started around 2016, the project had some difficulties, and we were certainly highlighted as having a we were very much an outsider in the pack in terms of our HSMR related to sepsis. Some of the region around 130 to 140 at that point, with, for those not used to looking at HSMR figures, 100 being the kind of the middle of the pack in terms of all NHS trusts. So clearly we started from a difficult point, and now actually our performances, we are certainly better performing in terms of our sepsis related mortality, and that's demonstrated both in terms of the yearly trends and the quarterly trends, where there clearly is spikes around winter pressures as to be expected. In terms of where we sit nationally, as I said to begin with, we were very much an outlier. We're very much now within the centre of the pack and trending towards the better end of the pack, and that's displayed in a slightly different format here, just to show that we are now very much moving in the right direction in terms of our mortality figures. And even within our local patch, again, we're sitting towards that lower mortality regarding sepsis. So clearly there is the right things are happening from the end point, which is what we want in terms of reducing sepsis-related mortality. The question is, how or why is that not reflected in terms of our Sepsis 6 performance, or is the Sepsis 6 really the be-all and end-all? That said, that is what we're looking for as one of our performance indicators. So in terms of the things that have been giving us some problems, clearly training, staff turnover, maintaining competency and engagement with the project is something which we're continuously trying to drive forward. We've already mentioned COVID has had an impact in terms of the patients we're seeing, and also our ability to capture what we're doing for those patients. That said, we have changed the audit process in a similar time, so there may be a dual effect here, where actually our audit data has become far more robust in the last 6 months to a year or so, because previously we were collecting the auditable data being a sticker in a folder on the wards when people had completed the process, so we were kind of auditing what should have been the best of the best, really. And now we've taken the audit a few steps further back, closer to the trigger point for sepsis screening and assessment. We're looking at when new scores are elevated, when that is escalated by the nursing staff. There is a sticker placed in the notes which we can now scan for within the medical records on EasyNotes and pull a direct sample per month from EasyNotes to then look at. So it's not quite as elegant as we'd like in terms of identifying our true denominator of all patients with a NEWS of 5 who should be screened for sepsis, but it's as close as we can get to it with a paper-based system at the moment. So that said, because we've had a larger sample and clearly we've had a more, probably more reflective sample of the patients we should have been performing the process for, I think it's clear that that's one of the main reasons why our performance levels have dropped. But I would probably say it's a far more reflective level at the moment than it was. So what have we done about it? We've been meeting with all the divisions. So Bellon is on the call. We met a few months ago now to discuss the paediatric and updates to the maternity sepsis screening pathways, which are really different patient groups to the adult population that we're looking at trust-wide. But trying to, they obviously have screening processes in place which we helped with when those were generated. But now how can we demonstrate that performance that they have in line with the other trust metrics on REN? So that's something that Ben and I have looked at. A large portion of the work's come within SCSD from Ed Mitchell, looking at neutropenic sepsis, and there is an update to the neutropenic sepsis pathway, which is nearly ready for sign-off at the moment. And I suppose the resurgence of the work at the minute is shifting the focus where we had good results focusing on ED in front of house a few years ago, using the same methodology within the Division of Medicine, and very much driven by matrons and governance leads and Sarah from a medical trainee perspective to help us try and get some local improvement there. So we've been looking at frequently asked questions and troubleshooting the process, surveying doctors, and bringing that all to the ward with a view to doing some local real-time auditing of the sepsis pathway, with a view to redesigning the process in a more user-friendly fashion and hoping to kind of pick apart the bits which are notoriously the most difficult to get right. So the real-time audit is aimed to kind of highlight where patient care could be improved, when it actually makes a difference at the time of that episode of care, rather than a retrospective audit, which is what we've relied on in the past, and dynamic feedback in training. The local quality improvement work has also looked at improving awareness of how to access blood gas machines in terms of measuring lactates, and about improving training so more people on the ward can actually process the sample, not necessarily interpret it, but that will certainly speed up interpretation from the junior doctors and advanced nurse practitioners when they review the patients. And a little bit more about what is expected of different roles within the team. So that's something which we've been doing over the last couple of months, and we've been meeting monthly with the Division of Medicine at the moment, and we're driving that forward. And there's been fantastic enthusiasm for medicine, so it's been really, really helpful from my point of view, and a lot of this has been driven by them. We are updating the pathway, aiming to launch that in August. So it'll initially be piloted in the medical division, and I'm going to be looking to show that to the other divisions in the very near future as well. So we've got close to what should be hopefully the final draft of the updated form, which will actually be version 4, but certainly the more user-friendly version. This is kind of how it'll look, just to simplify, identifying some red flag features that need to be treated for sepsis. But equally, if you don't have those red flag features, signposting to best practice treatment for patients with infection who could deteriorate with sepsis. And we've also updated the reverse of the form to make it a more user-friendly medical assessment, so how we're documenting our face-to-face review and really tightening up on what we're actually trying to treat. What are we actually doing in terms of modifying the early warning scores for the patients? Have we made sure that escalation plans are in place and the patient's been escalated appropriately, and signposting to those that need to be escalated readily? The way it'll all be triggered, again, this sticker that goes in the patient's notes was typically referred to as a news escalation sticker. I'm kind of going to try and move the slant towards this deteriorating patient alert, where we can identify we've got a patient who needs an assessment, and tying in whether the patient could have sepsis or they very clearly don't have sepsis, you know, they're having an eye or stroke or something like that, at which point we can then screen that patient out as having been effectively screened for sepsis. And that takes, again, it's another human factor step taken away, which should hopefully improve our screening performance, because when we scan for these stickers, we'll easily be able to say, okay, skip screens, not septic, and that will fulfill that criteria for us. If they are or could be septic, then clearly we go on to that pro forma, which I've already shown you. So that's what we're doing at the moment. So a lot of work in the background, certainly from the medical division at present, closely liaising currently with the neutropenic sepsis pathway in SCSD. And when we're happy this is going to work in that inpatient setting, clearly then we'll try and move into surgery again to get them on board with this. ED, I think, will take up the new version of the form quite readily because they're performing well as it stands.
Thank you, Mike. We've also got Bailon and Sarah, who were mentioned in this. Bailon from Women's and Children's, and Sarah, who's the Chief Registrar, who also came and discussed. Have you got anything to add from your divisions or from your perspective, Sarah? Oh, mine.
I think that Dr. McLinden has mentioned a lot of what we're doing anyway, and I'd like to thank him for his support with what we're doing in specialty medicine. I think, yeah, I would just agree with what he said about changing the form and having that sticker so we can really pull out those cases that are sepsis and ensure that they get the sepsis sticks, because medical patients are complex, multimorbid, have so many myriad reasons for having a NEWS of 5, and it's about really finding those ones that are really septic. We've got some other interventions going on as well, a newsletter for specialty medicine about sepsis, which has gone out and I've seen up on the wards of the walls, which is brilliant, a junior doctor's newsletter as well. And we're also, as Dr. McLinden said, doing some training around how to take Hilactate and where to process it, so I hope that will make a big difference.
Thank you. Bailon?
If it's okay, I'll just try and put up our slide as well so people can see. I don't know if it's in the pack.
It is.
I'll see. Can everyone see that?
Yeah.
Yeah. So, as I said, I met with Mike because sort of Women's and Children's has sat out and we've not really generated data. So we were in the sort of position we don't know what we don't know. But I'm very pleased to say that now actually we've got a gap audit for paediatrics and are producing data, and in fact we've got some data this month which I'll be able to present to CCG next month. Looking at it, but we've had excellent engagement. All the staff are being encouraged to complete their online training, and I think we've got a good percentage of the staff having done the sepsis training. We manage our Pew slightly differently, so instead of NEWS we have our Pew score, and we audit if a Pew score is greater than or equal to 3, that the nursing it's been audited by a nurse in charge of the ward manager to make sure that they've been escalated, and if there isn't, there's immediate feedback to the individuals. We have left the febrile neutropenia data out of it, mainly because it's really good for us, and what we didn't want to do was mask children coming in with sepsis for other reasons, but just to say in the last financial year, nearly 90% of children received antibiotics within an hour of arriving, which is much better than the national figure of 65%. And in fact, all but one received within 75 minutes. So there's been a lot of good work on there, because I think 2 years after I arrived, we were at sort of 0% with that. And then at neonates, we're actually going the other way. We know that a lot of neonates end up on antibiotics unnecessarily, which then means stays of 36 to 48 hours. And we're using the new Kaiser Permanente tool, which is being implemented regionally, to help reduce in a safe way the number of newborn babies receiving antibiotics. With respect to maternity, again, we weren't producing data, but now we've got the Sepsis 6 tool embedded in Badgernet, and we've done an awareness event, and we're hoping again to have some data in the next couple of months, and we're working with Amy Hunt from Informatics. And finally, breast joined us as a division, and they're extremely sort of low levels of de novo sepsis, but we are looking to see if we can get that data out. After the meeting with Mike McGillidan, we've now got things in place that we can actually present data, which was missing before.
So thank you also. The Quality Committee spent a lot of time going through this, and you can see the presentation is more detailed, and we were hugely heartened by the amount of work that's gone on. But I'm sure that any of our colleagues are happy to take any questions. Over to you, David.
Any questions from all of that? You've talked us into silence.
Anita's
there.
Oh, sorry, Anita, I can't see you. Anita,
hi there. Yes, I mean, thank you for that presentation and that information. I mean, I think for those of us who don't sit on QGC and who've been sort of concerned about sepsis for some time, that was actually really reassuring, and to see the progress and to see the data on HSMR and the rest of it, I think was really good. So congratulations for all the work you've done. I mean, I think this is great. Clearly the sort of the area which was clearly not on such an upward, or not quite in such a good place, was on the inpatient sepsis 6. If we go back to your first chart where it was very clearly an outlier, do you have, presumably you do have, that data that allows you to identify, are there particular wards or particular specialties where it is worse than others, where they're struggling more? And has that work enabled you to identify, are there some particular things in terms of processes that we need to support those teams to improve their sepsis 6?
Yes, thank you for the question. It is probably the most common question I get asked about the sepsis data, because as you can see, even if you drew a very generous line of best fit, it would be at most 40-45%. I think is fair to say, over the last few years for sepsis 6 completion. I think partly the challenge is that you're asking, a group of people who, there are a lot of patients who will fit into the possible sepsis group. So sifting out those patients who are genuinely septic is one of the reasons for using the screening tool. But even with that, it's a fairly blunt tool in terms of identifying true septic cases. So, and then once you have identified that, there are then the 6 steps that need to be completed, of which human factors then start to play a role. So the easy things to do are frequently done and done well in terms of administering antibiotics, which again is probably the key step in the treatment, if I'm honest with you. But it is a treatment bundle and evidenced as such. So giving oxygen, sometimes people are a bit wary with respiratory conditions. Typically processing lactates because of availability of blood gas machines, or the training to be able to physically process that sample. And then things like fluid balance monitoring, unfortunately, is historically difficult to get right, particularly if you are talking about catheterizing patients, which is another invasive thing to be doing. So there's a number of reasons why people may choose or not see. There's a lot of reason to be completing that whole treatment bundle. So I think partly it does rest around education, partly it rests around making it easier to do the right things and making it harder or more accountable not to do those things. So as with all processes, if somebody knows that they are being watched or being audited doing something, there is an added incentive to do it. And then if you are removing the barriers that make it more challenging, it also becomes less easy to justify why you're not doing these things. So we want to make it clearer from an auditing point of view why things aren't happening, and that will allow us to have more robust data. But also then educating and encouraging or reducing those barriers to why people won't do something is really important. So the e-learning has been helpful, I think has played a role. There will be some some necessary changes to that as we update the process. But the real local work that's been done in terms of knowing where your local blood gas machine is, or answering some of those frequently asked questions about oxygen and fluids and fluid balance monitoring are probably the key steps, I think.
I've got Matthew and Mike.
Yeah, thanks, Chair, and thanks to Sarah, Balin, and Mike. And Mike, I guess, leads on from Anita's question to some extent. I mean, we've been tackling this, and the board's been concerned about sepsis for quite some time because of the devastating impact it has for patients potentially. And from a learning perspective, what's the key thing that we need to get right that you've learned from the progress that we made on sepsis for other wicked issues that we're trying to deal with that have an impact on patients, do you think? Might be unfair to ask you that question, but what's the first thing that comes to mind? Because I think the learning from this is also quite important.
Yeah, I think the key thing is having the local engagement and having a team to support people doing local quality improvement work. So it's far easier for me and the two outreach nurses I have supporting sepsis to help support a divisional team who are engaged in trying to make local quality improvements, because if they're doing local auditing, if they've got some ideas about what they want to do, I mean, that is what I've hoped for all along, really, to then support that engagement. Trying to run it in a trust-wide fashion across 3 sites with 3 people, it's not impossible, really, because by the time you're focused on one area, a year goes by before we can touch base with those people again. And so what we have seen in the results is a sustained, focused approach gets in place the good starting points, and if they've gone, then it is engagement locally to then keep that driving forward. It becomes business as usual. And so I think it's taken 6 years for me to realise that that's the important point, and it worked well when we did that with ED, and I'm really hoping that it will do the same thing with medicine. As I said, for all the reasons Sarah's mentioned, medical patients are complex, it's very difficult to get that right.
Okay, Mike.
Yes, just 2 things. I'd echo what Mike said. It's about ownership. So ED own the problem, medicine are now owning the problem. SCST, I think, in terms of oncology, own delivery of the antibiotics. I'm not sure they're yet bought into all the other bits of the process, and that's a work that Ed, I know, is working with Mike on. The only thing I would add to all of that is that as we move towards the DCR, we got engagement already from the lead clinician in Allscripts to make sure that this is part of what we embed within the DCR, and that we embed it in a way that fits with how Mike has worked through how Worcester delivers this. So that will start to require things to be done, so it will make completion greater, in sense that people have to justify not doing things to get out of the system. So that will improve our recording. It won't, I think our outcomes are so good. I think Mike's work has shown that commitment makes that improvement in outcome better. The DCR will make our recording even better.
Okay, thanks. Okay, Julie, is there anything you finally want to say before we wrap up?
No, I'd like to commend the work that's gone on clinically and the leadership that's been shown by the people here, and also Nick, who's not with us today as well, in his division, because we've been going on about this for some time, and actually the progress was really heartening to see, and it's in depth and it's across the whole thing. So it's tribute to the leadership of the people here. I'd also like to thank Sarah as a, you're in training as well, and you've got an awful lot to do, but you've put an awful lot into this, and particularly the work you've done on forms across the trust was very impressive. We've not covered that today. Mike talked a bit about it, but we were very impressed by that work that's gone on as well. So I'd like to just pass on my thanks to everybody, but particularly to the leaders here.
Okay, well, thanks, Sarah, Balin, and Mike in particular for all of that. It's been really impressive to see it. I mean, people have already said that we've been banging on about this for quite a while, and I'm sure you have as well. And part of our job is to give you the tools and help and support you do these sorts of things. So feel free to talk to us about what extra we can do to make this happen. It's an obvious thing that has a massive impact on our patients. So thanks for all of that. I think the learning point, I mean, in terms of reflecting on learning points, Mike, I know you've been asked to reflect on that. The learning point, I think, for us as a board is sometimes a bit of exposure to the clinical people directly is a much more helpful way of taking it forward and thinking about how we work. So I think we've learned something from this as well. So thanks very much, everybody, and get it done, or whatever they say these days. Get it sorted. All right, thank you very much.
Thank you very much for inviting us, and thanks again to my colleagues for their help and support.
Yeah, thanks.
Thank you for your time. Thank you.
Okay. Let's then move on. We've got a couple of. I'm conscious of time, but I think it was worth. And thanks, Julie, for doing that, because I think it just made such a big difference. As much as we love Mike, and Mike's been manfully trying to persuade us that there is something about seeing it in the round that kind of helps you understand and get underneath all of this. So thanks for all of that. But the job's not done, as you know, Mike. We've got to get it. Got to get this sorted. Okay, I've got. We're going to have a conversation. We're going to have some time, I think, at another meeting about money to get underneath that, the 3-year plan and all the rest of it. So I don't want to kind of go on about it now. But I do want to talk about the thing about whether we are, in terms of our activity, we are actually getting to a point where we can start at least to stop the backlog growing. And whether we're actually being ambitious enough in all of this. Paul or Matthew, whichever.
Shall I?
Yeah,
Matthew? Yeah. Right. So where we are at the moment is that in terms of our activity levels that we're projecting, then just to give you some context, we're using the base year of 1920, so the pre-COVID year, and can I just remind board colleagues that in 1920 we really pushed to do extra activity, because that was the year that we said that we were going to try and eliminate long waiters to be the best in the country and have no patient waiting over 40 weeks. And you'll require, we got that down to 13 before COVID hit us. So that's my excuse that 1920 was a busy year. But that's the base year we've set ourselves. And as at yesterday, in the three main indicators that the board should be focused on, and certainly nationally they're focused on, is new outpatient activity, day case activity, and inpatient elective activity. And as I said, as at yesterday, if you look at the number of new outpatients we did in 1920, then it was 179,000 in the year, and our plan at the moment is 151. If you look at day cases, we did 86,000 in 1920, and our current plan is 70,000. And if you look at inpatients, we did 8,000 in 1920, and our current plan is just under 5,000. So on those three key indicators, you can see that our current projected activity levels for 21-22 are below the levels in 1920. In the first quarters, though, they are above the elective recovery fund target, which is set nationally, and that sets a target of against 1920 activity levels of 70% in April, 75% in May, 80% in June, and then 85% in July, and flatlined for the rest of the year. So that's where we are at the moment. I will be providing Matthew with an update. I think I have till 5 o'clock today to work it through, but we've been doing further work, which in part colleagues in Julian's division have been focusing on, which is reversing the IPC protocol that we've had during COVID, where we've been most of the activity through theatre has been sequential. So a patient's gone into theatre, gone into the anaesthetic room, from the anaesthetic room to the theatre, went in theatre, the tube removed, and then going on to recovery, and then the next patient's called. That's now been reversed, and we're back at 1920 protocols. So we expect that will enable us to increase our day case and inpatient activity, and we're just finalising, as I'm speaking, the impact that will have with divisional colleagues. Secondly, as part of that, on the Alex site, you'll know that we've started the switch over of elective work. We've reopened fully urology and orthopaedics, colorectal and upper GI, and gynae and breast are now taking place there. We have had to use Theatre 6 for a recovery, again linked to COVID protocols, and we're looking to bring that theatre into use, which will give us an extra 10 sessions. In addition to that, the system has funded a Vanguard theatre, which is basically a posh name for a mobile theatre, which we will have for 4 months from August. Initially, we were planning to do low volume, complex procedures there, but we've had further discussions with our CCG colleagues, and we've now agreed that we will use that Vanguard theatre for high throughput, lower complexity cases. And we're just finalising the numbers, but it looks as though we will be able to treble the activity that we will get through the Vanguard by making that switch. And then finally, we're looking at the potential to operate the Vanguard for at the moment it's planned to function 5 days a week for 8 hours operating a day, and we're just working through the potential for the Vanguard to operate 12 hours a day for 6 days a week, and also looking at the opportunity to use the theatres at Kidderminster for 6 days a week as opposed to 5, and there are 4 theatres there. And then finally, we're just working through looking at flow and whether we're being overcautious in our social distancing and how we're managing social distancing through our outpatient clinics to increase the level of new outpatient activity. We will not have the outcome of that latter piece of work until next week, but the aim at the moment is by close of play today to, on the elective side, the day case and inpatients, we're aiming to close that gap significantly between the gap at the moment compared to 1920, as I've said, is 16,000 cases a year, so just over 1,000 and a bit a month on day cases, and 3,500 on inpatients, so around about 500 a month. And for me to say anything, I can articulate what we're doing, but I wouldn't want to put actual numbers on that until we've completed the work this afternoon. But I'm able to share that with board colleagues after we've completed that work. So that's our main focus, and of course within that context we're trying to balance treating the long waiters with equally treating those patients classified as P2 and 3, which are clearly the more urgent elective cases.
Okay, thanks. Thanks, Paul. Simon.
Just an immediate reaction on that, Paul. I mean, I'm assuming we have the staff to do all these extra hours that we're building into the system.
In relation to the Vanguard, then the Vanguard is a staffed facility where it's a kind of we're buying an asset and service for that period. We do have sufficient capacity within surgical colleagues' job plans to undertake additional theatre activity within week. So if we can get Theatre 6 at the Alex Open, that's an extra 10 theatre sessions, and we have the capacity there. The thing we're working through is the nursing and ODP workforce capacity to be able to do that. So that's the one thing we're going through today. So just to finalise.
Thanks, Matthew, and then Anita.
Yeah, thanks, Chair, and thanks, Paul. And I think one of the tensions that that we've been working on, because inevitably you could argue, well, surely we should have had a plan already by now, having 100% delivery of 1920, is making sure that we're mindful of the cost and the workforce supply point that that Simon's referring to, because the two are linked. Clearly, we are on a process of trying to reduce dependence on agency staff, but as Paul says, the surgeons and the capacity in job plans, I think, is certainly in there, and obviously they're wanting to operate. Paul, do you want to just comment on the two indicators that the region particularly are asking for clarification from us on, and that relates to the dating of the P2 patients and also the clearance times? Just not too long a description, but helpful from a context perspective, just to reassure colleagues that that's all part of our planning around the activity levels.
Yeah, so in relation to the dating, we have had to hold back because we've been reconfiguring all the theatres at the Kidderminster and the Alex, so that we're allocating theatre sessions on the basis of need rather than historical allocation. And because we've been moving them all round, it's not been possible to date patients more than about 10 days in advance, because in switching all the theatres around between the specialties, we would end up, or we would have ended up, cancelling patients. The theatre schedules are now all sorted, and by the end of this month, we will be dating patients between 4 and 6 weeks in advance across all specialties for elective work. So that and colleagues at the regional office are aware of that. They acknowledge that the approach we've been taking is in fact sensible, and providing we are dating between 4 and 6 weeks in advance by the end of this month, they're content and believe that the approach we've taken is the most appropriate. In terms of the clearance, can I just simply say that it's a bit of a crude measure. It doesn't have any data set arrangements around it, and it's simply looking at the number of patients waiting, and then an interesting way of determining how many were taken off in a week. So if, for example, if there were 10 waiting and there was a view that 2 were taken off in a week, they divide 10 by 2 and say it'll take 5 weeks to clear. And that the way it's been interpreted across the region by different trusts is completely different. So it's not really presenting an accurate picture. And also the way the data feed was requested, the number treating or coming off in a week is not picking up the full activity we're doing. So it's a bit of a false measure, to be honest.
Okay, Anita.
Yeah, just a sort of a comment. I mean, absolutely, it's good to hear the plans, and and absolutely understand that things like the constraints of workforce and things are absolutely part of it. I just wanted to make a reflection, which is to say, I know we're all focused on this, but I do think there are, we absolutely need to keep this top of our minds. I mean, it's not just about, minimising patient harm, and I know we all understand that, but I think there is, there's some. I went to a really interesting seminar yesterday where they were presenting a research paper about the impacts on different socioeconomic groups or about access to elective care and emergency care. When I get the deck, I'll share it with anyone who's interested. But there was a really telling correlation between the longer people are waiting for elective care, it affects our front door in ED because they will, and the people that are going to come to ED are likely to be lower socioeconomic groups, which means that in terms of our desire to do something about population health inequalities, it's not helping in that area too. So I think I know we all know this stuff, but I think there are really 3 good reasons there that we absolutely need to keep this top of mind. So thanks.
Yeah. Okay. I'm going to wind it up now, but I think Matthew wants the final word.
Yeah. Thanks, Chair. And Anita, I think you're absolutely right. It kind of plays back into my earlier point about that unmet need. I've no doubt some of that unmet need that we're seeing now coming in is as a consequence of these delays, which is absolutely why we need to be driving activity as high as we can, as quickly as we can. The conversation I had with the CCG is around how we make sure that it's realistic, ambitious, but there's also clarity in relation to how this is all going to be managed from a cost perspective as well. Because first and foremost, we've got to put patients first and get them treated. But we will incur additional costs through the emergency pathway that we could eradicate if we put additional resource in up front for recovery of waiting time. So absolutely agree with that, and that's very much our focus.
Okay, thanks for that. So obviously, Paul, you're not going to give me any numbers, even though I might ask you for some numbers. But is it your expectation that we will get closer to the benchmark, middle of the pack sort of thing in the region, whereas at the moment we seem to be slightly an outlier? Is that your expectation?
Yeah.
Okay, that's enough for me. Paul Brennan said it. Thank you. Okay, and just finally, the point that Simon made about the assurance and dates. Can I ask Rebecca to work with the chairs to see how we can put that in a better place for us going forward? Thank you. Okay, let's move on to the committee assurance reports. Can we take them as? Is there anything? Hold on, I'll just. Sorry, where are they? I've lost them, Rebecca. Where are they?
We're at page 90. The reports have been written, so simply a matter if there's anything that the particular chairs risk or escalate that's not already covered in their written report.
Yeah. Okay. So finance and performance committee report. Committee. Anything? No. Okay. Fine. Quality governance. We've covered most of it.
We've covered a substantial part of it. We did also talk a lot about infection control, about antimicrobial stewardship, but Mike's doing some detailed work in that, and again, we were pretty pleased with that.
Okay, thank you. Okay, that's that done. Thank you very much for that. Let's then move on to the nursing and midwifery staffing report.
Thanks, Chair. So yeah, I'll do the nursing bit, and then Justine's here, so she'll do the midwifery bit. So I've just got a couple of points to make on the nursing. So staff continue to be deployed to provide the safest staffing levels across the trust from a nursing perspective. There were no patient harms reported, and there was an increase in reporting, which is a sign of a good culture. Majority of staff have returned to their substantive areas. There are still some staff required in critical care. And just for everybody, I'm sure you were all aware, it was International Nurses Day yesterday, and it's National Nurses Week this week. I was out and about on the Worcester site, which was really interesting, and met with some dental nurses and talked about their redeployment to wards but not to critical care, and some of their sort of fears really about the fact that they'd never put a patient on a bedpan, they'd never washed a patient, and that they were literally told to just, because they were nurses, that they should be able to do this. So I've picked that up, and from a fundamentals of care perspective, we'll look at that, because we don't know what the future holds as such, and we may need to redeploy again. And they were very much enthusiastic about going into these areas and helping, but still quite fearful about, even to the point that the sister said, yes, I can work as a healthcare assistant, but I still need to know what I'm doing, because I'm a dental nurse. And you know, I put it in perspective, you'd find many general nurses not be able to do a dental nurse's role either. So that's something I picked up on my journey through the trust at the moment, and that's all I needed to say on the nurse staffing, unless there was any questions.
Thank you. Any questions? Okay, thanks very much for that, Paula. Justin.
Thank you. Just a few things. I'll take the paper as read. Just to highlight the ongoing challenge that we face. We did unfortunately have a busy month following a quiet month in February, which you'll see on our IPR. Our births were down, but our February babies, I think, joined us in March. We still see higher levels of sickness, but our HR business partners are working with us to address those. Regrettably, we had to cancel some role-specific mandatory training in month to direct staff back to the clinical areas, which obviously is paramount for safety. And the sickness and additional theatre roles remain our top two reasons for not meeting acuity within our intrapartum areas, and we're doing some work around that. So the positives, we've had 10 new midwives now in post, and we've got a further 6 that we're waiting to arrive for our community services, so that's really positive, and we expect them to be in post by Q1. We've got start dates for all. We shortlisted and interviewed a further 21 student midwives who will be qualified in September, and we've made a number of offers there, more than we expect. We've got 17 offers made. We don't expect to recruit all of those students as their local services advertise over the next few months. We were ahead of the curve, so we will see some drop off there. We highlighted previously that some of our challenges were around our induction of labour pathway, and work is progressing with that, and also that's a co-produced piece of work with our MVP. We've now submitted our Ockenden bid in a hope that we can increase our uplift to support staff to meet the training requirements, the role-specific training requirements for midwives. As Paul has already talked about, within nursing there was an increase in incident reporting. That's continued within maternity service as well, so that's a good, safe culture that we're seeing there, but no harm was reported. We've explored additional roles to try and support the ward areas, particularly in terms of using nursery nurses, surgical nurses, with some mixed response. But we continue to try and change the culture in accepting help from other services, and just in an attempt to improve our reporting and monitor our acuity, we've continued with the procurement process for the acuity tools that we previously talked about, and our birth rate plus audit is still on track for being completed in May, June. Apologies for the background noise, I'm office sharing.
Okay, thanks. I'm very conscious, Simon, I missed your hand up. Did you want to say something about the nursing one?
It was just to acknowledge Paula's comment about the increase in reporting culture and how positive that is, but just to sort of ask her what follow-up comes from that, and how much are we seeing a change as a result of that reporting culture, because I know when staff do go to the trouble of reporting incidents, it's good to see that follow-up. I'm sure that's in place, but it'd be helpful just to get Paula's comments. And then just a remark about staffing and the dental nurses, if I can mention the name of Mark Britnell around this table, ex of this West Midlands parish, in a book he wrote quite recently about the future of staffing in healthcare globally. He was sort of envisaging peripatetic generalists, people who are able to do more than one thing even though they're employed to do a specific job. That may be something that I think the NHS is looking at through the people plan, but I think it is something that we need to look at, how flexible colleagues can be to meet the increasing demands the system's facing.
Yeah, absolutely. And but I think the reporting culture bit also applies to maternity as well.
It does.
So if both of you could say something about it, it would be really good.
Thanks. So yes, there is a feedback mechanism within Datix that they can receive feedback, but they should be receiving feedback from their ward managers and their department managers to say they've had the incident report, they've acknowledged it, and they've managed to do managers' actions to close that down, rather than it needing escalating to a serious incident if there is harm. So they should be getting that. But Simon, I maybe need to explore that a little bit more to understand that they are getting that feedback.
And I think it's also that point about sometimes this impacts upon their managers directly.
Yes.
In terms of the incident itself and how we support the middle manager, the managers ultimately, so that the system works best for everybody.
Thank you. I'll pick that up at senior nurses this afternoon.
Okay. Right. Any questions on the? I know we're going to have a further discussion in the private part of the board on maternity generally, but any points in relation to this? Can I just add if you look at on page 119, it says the level of assurance provided from safe maternity staffing is 4. This is a decrease in assurance levels from the previous month, as despite an action plan agreed to address staffing issues, some of these actions have yet to demonstrate an improvement. That's a bit of a problem, isn't it, for us? Because in a sense of all this action, all this chat, but actually nothing's improving. Can you just unpack that for me, Justin, so I understand what it actually means?
So I think because it's so multifactorial, as quickly as we're resolving one aspect of the problem, other issues are impacting on our ability to maintain our safe staffing levels, and we're heavily reliant then on some of our other services. Our community midwives are supporting us, and our continuity of care and midwives are supporting us, and that is less than ideal because it then has an impact obviously on their workload and their work-life balance. So although we are managing to maintain safe staffing levels, it's still on it feels like a day-to-day basis. Obviously this is a report from March, and we're now in May, and you can see that within that report it talks about further recruitment and people expected back to work in terms of clinically vulnerable staff, and also staff who have needed to self-isolate because of contacts with COVID, which are massively reduced. So April, well, I know we're talking about March, but April is an improving picture. So the actions that we have outlined are starting to have some impact finally.
Fine, thanks. Okay, do we take that for assurance, that report? Thank you very much. Thank you for that. Let's move on to the provider licence conditions.
Thank you, Chair. This is a declaration that the Trust is required to publish on its website. If bearing in mind time, I'd like to give you assurance that this has been reviewed at multiple committees through Trust Management Executive, through the Quality Governance Committee, and also the Audit and Assurance. A number of the compliance statements are returned as non-compliant. 2 of those are primarily in respect of the underlying structural financial deficit position, and also in respect of the licence conditions. Certainly looking forward to next year, we may well be in a position to flip one of those back to compliant. The evidence is set out within the document, and it has been reviewed in detail at committee, so I simply ask board to agree publication of the report as reviewed at this point. Happy to take any questions. Thank you.
Can you just say again, Rebecca, the 2 things that we're not compliant on?
One is in respect of licence condition, in respect of the Trust having conditions upon its licence. So that is at page 126, it's section 4, and also in regards to the first one in respect of the overall corporate governance position. Like I said, the underlying elements to those are the conditions upon our licence in respect of section 31 and the underlying financial position. I'll ask Robert if he wants to update further in respect to the finance. Thanks.
No, can I just so I understand the section 31 stuff? What are the outstanding conditions on our licence now then?
This is simply a timing issue. So this report covers the year prior. We've subsequently made an application for those to be removed, which we understand has been successful, and that will drop off next year. However, this is a retrospective statement.
So it's all basically this to get us compliant for this for next year, this is all related to our ability to have a robust plan to get ourselves into a better financial position.
Yes, in part. I'll hand over to Robert.
Okay.
No, thank you, Chairman. I mean, the particular line in there is about our ability to continue as a going concern. The real position is less that because we are a going concern and we've certified ourselves as such. It's actually the fact that we do get referred by the Audit Act because we're not able to meet our cumulative break-even duty or to get a cumulative surplus. So over the years we built up a very substantive deficit position cumulatively, and actually in order for us to be compliant in that one we would have to be in a cumulative break-even or surplus. So it's not even about getting it in 1 year, which we've done of course last year, 2021. It's actually been able to either write off effectively very significant 300 odd million pounds cumulative deficit, then you can declare that you're compliant.
I thought the department had done that.
No, they paid off our loans, not our deficit.
I thought they did that for everybody. I've obviously got that wrong, haven't I? Okay. So it's a fairly bleak comment you're making there, because the chances of us making a 300 million surplus in the next year is unlikely, even
Yes.
with your skills. Yeah.
Thank you, David.
Okay. Is it? Well, it's a funny way to run a business. Anyway, okay. Okay, so, but certainly one of them we should be able to get rid of by next year. And hopefully there'll be a change in the regime which will allow us to get rid of the other one, because it seems nonsensical. Okay, so we approve that. We approve the response. Thank you very much. Audit and Assurance Committee. Anita?
Thank you. Yes, please I'll take the report as read. Just to flag that we did actually have a meeting earlier this week where we were made aware of some work going on at the moment. We are confident with the validity of our data. So just to say, there's an action plan in process, and we'll be monitoring the situation going forward.
Fine. Okay. That's good. We take the report for assurance. Thank you. Remuneration Committee. The shortest remuneration committee ever in the history of the world.
If that's you, Chair, I think we can take the report as read.
Yeah, I think we probably can. It was just that Matthew had referred to it earlier on, and just to reinforce, it's been a really good response to the medical director job. Really good. I think it reflects well on what Mike has made of the job, but also the improvements that we've seen around the hospital. So well done, everybody. Good. Trust Management Executive.
Yeah, thanks, Chair. Take the paper as read. I think the key piece for us now is making sure that we're very clear on how we're going to oversee the transformation agenda that we've got underway, and how we make sure that that's properly overseen and governed, and that we really make sure that we pull all the interdependencies together. So Rebecca and I are just doing a bit of fine-tuning on the approach in the Trust Management Executive, but colleagues will be familiar with most of these reports through the subcommittees.
Yeah, got plenty on. Plenty on.
Yeah, I guess back to my earlier point, we really need to make sure that we are sequencing all of the good work that people are leading in a way that realises the maximum benefits and doesn't just knock us off course as an organisation.
Yeah. Very good. Okay, well, thank you very much. I will take that report for assurance. There was no other business. So thanks, everybody, for your contribution. We've got we're going to go into private part of the meeting begins at
12:30, Chair.
12:30. Excellent. So you've got 22 minutes to do whatever you want to do. So have a nice time, and I'll see you at 12:30. Thank you.